Good afternoon. Thank you for joining the We Can educational series. Today, Dr. Lynn Sheets will discuss sexual activity in minors and when it is reportable. Dr. Sheets is a child abuse pediatrician and medical director of the Child Advocacy and Protection Services program at Children's Hospital of Wisconsin in Milwaukee. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for your participation in today's session, you must track your attendance by texting today's code to 414-206-1776. The code will be displayed at the beginning and end of each month's session. The code will activate at 12:30 p.m. Following the presentation, you must log into your account at ocpe.mcw.edu and complete your evaluation within 10 days. Refer to the housekeeping PDF in the handouts area for more information. We have recently updated the layout and information available on our webinars page. To see the changes and to view a list of future topics, please visit wichildabusenetwork.org/webinars. And now we'll proceed with today's presentation.
Good afternoon, everyone. This is Dr. Lynn Sheets. Thank you for that kind introduction, Sarah. Today we're going to be talking about a new topic for We Can, and that is sexual activity in minors and when to report. It's a medical perspective, but that doesn't mean it's not relevant to non-medical participants. I hope by participating today that you will be able to understand the medical perspective somewhat better and understand why in some situations medical providers may not be reporting sexual activity in minors because it may be covered under an exception. I'm also hoping to, if time permits, to get to some resources for topics that intersect with this topic. And even if I don't get to that, those are included in your handout. I did not put pause slides in this presentation. It was an inadvertent omission on my part, but I will be stopping periodically and addressing any questions submitted through the question pane. So with that in mind, we're going to be launching into the topic. I'm going to give you an overview first, and that is a little bit of overview about brain development in children, particularly teenagers. As many of you may know, there are multiple developmental events occurring in the teenage years. There are physical changes, cognitive changes, emotional changes, behavioral changes, and social changes happening with teenagers. Their peer group is often in flux. Their schools are changing from middle school to high school. The family structure sometimes is changing for a variety of reasons. And there are alterations in societal and community expectations. The parenting styles that are somewhat authoritarian may make some of these just normal teenagers at increased risk of maltreatment and risky sexual behavior. Despite the appearance that the youth are more adult-like, they are actually less able to protect themselves during their teenage years, particularly regarding high-risk sexual situations. They're more vulnerable to factors that lead to their victimization, as illustrated in a publication by Finkelhor in 1995. They have risks of giving in to social pressures and engaging in behaviors that impair their ability to protect themselves, such as substance abuse or use. They also have a desire to fit in. That's very important to the brain development. They usually want to fit in not so much with the family, but with a peer group. And that makes the youth more likely to accept abuse in the context of a relationship and less likely to make a report. So it's much more difficult for a teenager to disclose to a protective parent or to a protective adult that they've engaged in a risky situation or even abuse when it happens. Their prefrontal cortex is also immature, and their brain is essentially growing, and I'll talk about that a little bit more, but essentially the part of the brain involved with impulse control and planning, basically the executive functions of the brain are uh, are impaired, we'll say, or not fully developed. And some will call the prefrontal cortex the area of sober second thought. It's also the area of informed consent from a medical perspective. So this is a really challenging age for medical providers to deal with. It's also very challenging, I think, when bad things happen. So I'm sure from a CPS and law enforcement perspective, you have similar challenges to the medical profession. The adolescent intrafamilial abuse can result when the family fails to adapt to basically all of these changes that are happening and the emerging autonomy of the teenager. And so that the child is no longer completely controlled or dependent on the family, which can create tension and even overt abuse or physical abuse situations. Sometimes what we see are cases where abuse has begun early in childhood and then continues into adolescence, which is not the typical scenario, but we certainly see that. Approximately 20% of childhood abuse involves youth over the age of 12 as perpetrators. So we also have to think about teens as potentially perpetrators of abuse, which can create some challenges because from a medical perspective, even though they may have perpetrated on a younger child, the teenager is still a child. And so this can create some tensions, I would say, between the legal and child welfare systems and medical providers. So kind of a combination of all of these legal, consent issues, peer pressures, other issues listed on this slide. I mean, we're talking about a very challenging situation when teens engage in risky behaviors and sexual activity. So as all of you probably know, April is Child Abuse Awareness and Prevention Month, and appearances can be deceiving. We've seen a lot of winter lately, and very few of us, I think, are happy about that. My dog was very happy about that, but what we'd like to see are lots of flowers. And in the same way, teenagers, the appearances can be quite deceiving, and you'll often hear this said when you hear law enforcement and child welfare wanting to interview teenagers about sexual assault and not taking full advantage of a forensic interview. I think there's a typical mindset that a teenager is a young adult and often are treated as young adults in our criminal justice and child welfare systems, despite the fact that they are not, they are still children. And so I think it's a bit off topic, but I do want to encourage you to have some second thoughts about using your Child Advocacy Center forensic interviews for children, even teenagers who have disclosed sexual abuse or sexual assault. It can be a valuable tool in holding people accountable. So teenagers are children. The different parts of their brain are maturing at different rates, and brain development continues well into the mid-20s, and for some young adult males, it's in the late 20s that you get full maturation. This, the last brain structures to really fully mature, as I mentioned, are the prefrontal cortex, which is in charge of the executive functions, or kind of like air traffic control of the brain. And this is the part of the brain involved with decision-making, understanding outcomes, impulsiveness, inhibition, focused attention, prioritizing, problem solving. So this is a key factor. I mean, you have an adult-looking person who is very interested in sexual matters, and you have the part of the brain that keeps the body and the brain safe, very immature. And this combination leads to risky situations, including sexual activity. So this is just a schematic or a diagram illustrating what I've just talked about, is that from about age 3 until the mid to late 20s, the brain growth is actually slowing. It's not growing as quickly, but it's still growing. And the parts of the brain that are becoming more and more mature are the prefrontal cortex and the gray matter of the brain during this time. The early adolescence, this period here in the 12 to 14 years of age, is really a peak time of child abuse and neglect, according to the National Incidence Study published in 2010, the 4th National Incidence Study. Most of you, if you've heard me speak before, I'm usually talking about this very young period of time when children are under 3 years of age and early physical abuse. But we see another peak in child abuse around this 12 to 14 years of age, and it's a combination of what I've already mentioned as far as factors. So there are risk and protective factors that are really important. Risk factors, I know all of us like to be more strength-based, but we have to think about risk factors, and I think most of us know that family dysfunction is a major risk factor. Truancy, family or social isolation, so it can be in a family context or an isolation from peers, and a history of maltreatment in earlier childhood is a risk factor. Protective factors that are evidence-based are parents who are very involved in their child's or children's lives, family dinners where the family sits down together without a screen on, without a TV on, and talks and shares a meal together, school involvement, and then mentors and peer support. The CDC in January released a report about sexual activity in minors, and they looked at a period between 2005 and 2015 and surveyed or looked at how often high school students were having sexual activity or engaging in sex. And the average age was actually 17, according to this study. Between 15 and 19, 44% of females and 49% of males had their sexual debut. That's a term I'm not particularly fond of, but it's often referred to that way. Those data are somewhat in contrast to some earlier times or greater sexual activity indicated through the National Survey of Family Growth, and that was through interviews of youth. So I would wager that the CDC data are somewhat of an underestimate. So it's important for me to pause at this point and mention roles, and we'll talk a little bit about statutes here in a few moments. But the medical role in reporting sexual activity when it's under the age of 18 in Wisconsin is really quite different than the role of other mandated reporters. And as you know, I'm a child abuse pediatrician. I'm speaking from a medical perspective. So it's really important as I'm going through this talk today that you keep in mind your own legal mandates as a mandated reporter, if that applies, and that if you have any legal questions that you go to your legal counsel and get those addressed, because I am not providing legal advice. I'm simply providing one medical perspective. So this is a resource that if you haven't seen it, I would encourage you to take a look, and especially if you're wanting to look at state-to-state laws and how they vary. The Guttmacher Institute is an excellent resource that is updated frequently and really stays abreast of what's happening with laws throughout the United States pertaining to reproductive health, care, and confidentiality. Another resource is this by Fuentes that found 1 in 5 teens in between age 15 and 17 reported that they would actually avoid medical care for sexual and reproductive health if there were confidentiality concerns. This is a major issue for medical care, and I know there's been some push in the last few years to tighten reporting of adolescents who are seeking reproductive health care. And I would encourage you to think about that critically, because we know from good evidence published in the scientific literature that doing so would come at a heavy cost, that many of these youth who currently will be honest and disclose what's happening to their healthcare provider would stop doing so, and they would stop seeking health care, which would have enormous social and healthcare costs associated with it. So where are teens getting their education these days regarding their own sexual health? So there have been actually several studies, but this information is from the Guttmacher Institute, and there has been a decline in teen girls' reports of getting formal education about birth control, STIs, HIV, and AIDS, possibly in part due to a decrease in sex education in the schools. In addition, there has been increasing marginalization of LGBTQ plus youth. In 2015, fewer than 6% of websites where youth were getting information had positive or at least neutral information about gender identity. And so often LGBTQ and gender issues are being portrayed in a very negative fashion on some of these websites. 73% of the teens aged 13 to 17 own a smartphone, and it's probably, even since I pulled this talk together, that's probably increased. And we know that 46% of websites contain inaccurate information about contraception. So this is in the context of brain development, in the context of what information is available to youth that's accurate. This is really setting our youth up for some dangerous situations. If you look at sex education in the schools, we know it's declined since 2000. And if you look at 2014, it's really dropped quite a bit in terms of really all types of sexual education. So kids are turning to the internet to get their information. This is having bad consequences, and particularly for our youth who are at increased risk. So I pulled some information here about foster youth. If you look at female foster youth, ages 17 to 18, they're at increased risk already of having a pregnancy by age 17 to 18. If you look at by age 19, if they've ever been pregnant, 51% have been, versus only 20%, which is still a high number in all female youth. These numbers are unacceptable, I think. And so we need to think about targeting prevention efforts to girls, teenage girls, particularly those at increased risk, and that includes foster youth. And mandated reporting, which is, while it's the focus of this talk, it's, I think, going back to the statute is not necessarily the focus. But I want to remind you that every state in the nation has a slightly different statute, but Wisconsin statute requires a reasonable suspicion, which is a pretty low threshold. It's more than a hunch. but not much more. It's in the course of one's professional duties, which varies somewhat from other states. And it refers to either has been or will be abused or neglected. And so it has this future tense in the Wisconsin statute that some other states don't have. It includes suspicion of sexual abuse, but in Wisconsin, there is an exception for healthcare providers, and that's where we're focusing most of our attention today, because healthcare providers do not have to report teenage consensual sexual activity if they are providing reproductive healthcare services, and that's a really important point. However, routine reproductive health services implies a duty to screen for sexual abuse or coercive situations or non-consensual situations. So I will be talking about that through the next several slides. In general, it is our practice here at Children's Hospital to recommend, in most cases, reporting both to CPS and law enforcement when a report is made. And state statute, I think, directs that child sexual abuse will be investigated jointly by CPS and law enforcement. So again, I'd like to point you to your Child Advocacy Center because forensic interviews in these situations can be enormously helpful. Remember that teenagers, when they do make a disclosure or an outcry of sexual abuse, often recant. And so capturing that initial outcry can be very helpful. Also keep in mind that the teenager is rapidly changing. The words they use will change as they get older. The way they disclose will change based upon kind of how they've gotten feedback from their peer group. And their physical maturity will change. And so how they look now when they're making an outcry will look very different than maybe as the case is litigated. And so even though the forensic interview may not prevent them, in fact won't prevent them from having to testify, it can be very, very helpful as one part of the evidence that the court can use and that the jury and judge can use in making some of these determinations. I'm going to turn to the question panel at this point. And a comment is being made that a policy by this particular individual requires them to report all sexual activity of anyone under the age of 18, even if it was consensual. I don't know the role of this person, so I don't know if this is a medical provider making this point. So it's hard for me to comment about this. If you are a teacher, this kind of policy would not surprise me at all. As a medical provider, there is, if this is a medical provider's perspective, I think there would be a very legitimate reason to push back on a policy requiring you to report all sexual activity. And in fact, there may even be a legal issue there, but you would need to talk with your legal advisor, because you also have a duty to provide routine reproductive health. Regardless, if you are in a position where your agency as a medical provider is requiring you to make a report involving routine reproductive health care in a sexually active teen, if you are in that position and you're unable to change that policy, then I think you have a duty to tell any teenager the limits of your confidentiality and make sure that they understand it. So I would use a teach back tool or some other tool to make sure that that teenager understands your limits of confidentiality before you even talk with them. And that's how I would manage that situation. So back to the talk today. I want to remind you about parental rights in Wisconsin. This is also somewhat of a challenge because in Wisconsin, the parent owns the minor's medical record. And so even if you can limit disclosures to the parent because you're providing routine reproductive health care as a medical provider, the parent still owns that medical record. And so explaining that to the child, to the teenager is important. And then the limits of your confidentiality is critical. And then also encouraging the youth to have more open conversations with parents, because ultimately the well-being of the youth is usually, not always, but usually best served if the parent understands what activities the teen is engaged in and can be an advocate and ally in the health and well-being of the teenager. So are there any age guidance rules or laws in Wisconsin? The answer is really no, there aren't. Healthcare providers in Wisconsin may provide reproductive health services to sexually active teenagers without a duty to report. But in doing so, the provider should screen for situations of coercion or unequal power, and we'll talk about that in a bit. We recommend use of a tool, the ASVAST tool, which I will show you in just a moment. Most healthcare professionals would report sexual activity involving children who are younger than 13, but that is just a general guidance. It is not in statute, and each case must be considered individually. Any disclosure of sexual assault, rape, drug-facilitated sexual contact with an authority figure or a parent or a caregiver, or unwanted sexual contact involving another child, even if that child is, or another individual, even if that individual is under 18, should be and must be reported. So in practice, we get into some sticky situations. Now, what about reporting when you have a 15-year-old who is seeking birth control? In general, assuming that there's not a positive screen, and we'll get to that in a moment, we would not necessarily report sexual activity in a 15-year-old just seeking birth control. And that's the medical perspective, because there's a medical exception. So what if her boyfriend is 19? Well, some people would use 5 years age difference as a critical age difference. Some people would use closer to 10 years. And so 19-year-old, not necessarily, but again, you would need to screen for coercion and other reporting situations. But what if that boyfriend is 25, 30? Then it becomes clear, and I think most people would recommend reporting when there's a significant age difference or a developmental age difference that's significant. What about a 16-year-old who reports being hit by her 18-year-old boyfriend? Is that a reporting situation? And the answer is yes. In that case, that's teen dating violence. We would consider that abuse or assault of a child, and that's a clear yes to reporting. So there are many other sticky situations, and none of these, I'm expecting my question pane to explode at this point. There are so many sticky situations that they almost have to be handled on a case-by-case basis. Again, I would have you turn towards your own policies, procedures within your agency, but also your own legal counsel, because we can, if you want to call our team, we can sometimes help advise you, but ultimately you're bound by your own agency and the Wisconsin statute. And then there are other sticky issues that if we have time we'll get to, but basically you can release records if there's an active Child Protective Services or law enforcement investigation, and you can do so without consent. What about taking photos when child abuse is a concern? Yes, you are protected under the immunity statute, so it's kind of a back-end protection, but you can do so if you're a medical provider. And then what if a teen, even though an evidence collection kit is indicated, but the teen refuses to have a rape kit collected? Or what if the teen has altered level of consciousness and unable to consent or assess? Then in those situations, we do not collect them. But again, you have to follow the policies and procedures of your agency and the laws. So about 1 in 4 girls by the time they're 18 and 1 in 5 to 10 boys will be sexually abused or assaulted. These are appalling statistics, in my opinion. Risk factors that we know are growing up in a home where only one caregiver is present. Domestic violence in the home increases risk of sexual abuse, particularly of girls. History of sexual abuse in any of the children or in a parent. A mentally ill or drug-using mother basically makes her unavailable and increases risk to the children. There's a 3.6 time increased risk if the mother was sexually abused. We also know that disclosure is a problem. We know that only 18% of women who were sexually abused as a child disclosed the sexual abuse or assault within 24 hours. 58% of adult child sexual abuse survivors disclosed the abuse for the very first time as an adult in one survey by Alagia, published in 2004. And they say the reason they didn't disclose initially is fear for safety, shame, and a lot of self-blame, anticipated futility, people won't believe you, nothing will happen, the impact on the family, this tears families apart, and then loyalty to the offender. This was Ressler and Wind, published back in the 90s. Once teenagers do make a report, if they do, they tend to be tentative reports. They're vague, and they say, well, maybe, not sure it happened. It may have happened to a friend. It may have been a dream. I don't remember the details. And so their report can often be very unconvincing at first. And depending on how the system, including medical providers, CPS, and law enforcement, respond, they may recant or they may then provide a more convincing report. The prevalence of child abuse, child sexual abuse is really quite high. I've mentioned that. Just some data for you. There are lots of barriers to reporting. And so we know that 27% of healthcare providers admitted to not reporting injuries to a child that were likely from abuse. And there are lots of barriers that, from a medical perspective, of why they don't want to report. And here I'm talking about mandated reports from a healthcare provider. They have a relationship with the family. They may think that this was a one-time incident. They didn't have previous suspicion. Therefore, they think that they're going to manage it, basically one-on-one with the family. They reason that care was sought promptly. Therefore, maybe the abuse really didn't happen. And then they anticipate that there will be negative consequences to the child or to the family from reporting. They may also have a sense that I've reported before and nothing happened. So I think there's a push nationally that you'll be hearing more about in the next few years to increase information sharing between CPS and medical providers, because that relationship ends up being critically important in reinforcing reporting by medical providers when there's reasonable suspicion. So who to report to? Again, I've mentioned we encourage reporting to both CPS and law enforcement for lots of reasons, but I think this is best practice, and this is actually reinforced in Wisconsin statutes where joint investigations of sexual abuse occur. So if you do make a report, it's not just a check the box, I made a phone call, done. It's not, the value of that report and what happens after that report is heavily dependent on CPS and law enforcement understanding the report. So it's an opportunity for education. And if you're CPS and law enforcement, it's an opportunity to ask lots of questions and dig deeper as to why the medical provider is concerned and why, what are the strengths of the family, what are maybe some of the risk factors, and what made them pick up the phone that day. Because the medical provider often has a lot of additional information that can help CPS and law enforcement understand why this report should be screened in. Wisconsin has a law that many states don't have, but this non-caregiver law, and I think it puts at least some kids at risk. So then the Child Protective Service agencies often will screen out cases where a caregiver is the suspected perpetrator. Caregiver is defined pretty broadly as anyone who has cared for or supervised the child in or outside the home. But often when a non-caregiver is the suspected perpetrator, these cases are screened out. And I would encourage you, even in non-caregiver cases, to think about, was there a component of neglect? Because if there was, and here we're talking mainly about neglect of supervision, if you have a teenager who is essentially, I'll give you an example, has been AWOL for 2 days, gets trafficked by non-caregivers, that is a case, obviously, because of recent changes in the law around trafficking, that CPS should be screening those cases in and co-investigating. But if the kid has gone AWOL and gets maybe molested by their best friend's father, then in that case, where you don't have a trafficking situation, those cases we see sometimes get closed or not even screened in prematurely. And those are the cases where the medical provider should be reporting not only the sexual abuse or sexual assault, but also concerns about neglect. I mean, how is it that a teenager goes AWOL and nobody is calling the police from the family isn't calling the police? So there's certainly a concern about neglect in a case like that. So this is a case example that just illustrates some of these cases, but JM was a 14-year-old male who males tend not to disclose, and this is a good example of that. He had a previous history of sexual abuse, and he came into the pediatrician because he had acute rectal bleeding. He didn't know why he had it. He said he was just getting ready for school, and he felt some cold on his butt and saw some red stuff. He denied any trauma other than all he could think of is the previous day in gym class. He was sitting on the floor, and he had been kicked 2 times while he was sitting on the floor on his butt. But he didn't think that that had caused the injury. He also reported falling down the stairs, but didn't think that had caused it. He denied abuse. He denied any sexual contact. His genital exam was normal, but his anal exam was not. And so if an anal exam is going to be offensive to you, you might want to avert your eyes. But on anal exam, this boy had stellate lacerations, which you can't see very well on this single photo, but he also had some perianal contusions and venous pooling. You can see that some of this, some of the what appears to be bruising actually blanches out a little bit under some tension of the skin. So you're seeing here a combination of venous pooling as well as bruising. We suspected at the time that he had been likely gang raped, but we don't know that. We suspected significant anal penetration on the basis of the injuries, but he continued to deny. And obviously this was a reporting situation. We tried to get him into mental health therapy. The family was not compliant with that, and we never did find out what happened. This boy did have an evidence collection kit. So, I mean, these situations, the case I just told you was a case clearly, even though there was no disclosure, is a clear mandated reporting situation. But there are lots of other situations involving teens that are less clear. These teens may present to medical settings wanting STI testing or HIV testing. They may want contraception or reproductive health care. They may want treatment for a sexual abuse or sexual assault. They may be disclosing. They may already be pregnant and wanting care related to that. So this reproductive health care that medical professionals are dealing with is not clearly defined, but it's generally considered confidential. except in mandated reporting situations, which gets medical providers into a very challenging role where they're needing to have frank conversations with children, with teenagers, and provide as much confidentiality as possible in order to maintain health, but also screen for mandated reporting situations. So it's this conditional confidentiality is the recommended route, where teens are advised of the limits of confidentiality before they proceed in disclosing what has happened or why they're concerned. So this is just going through that, but basically it's this disclosure of what the limits are. And if you're in a setting, as the previous question indicated, where you have your healthcare organization telling you you must report all underage sexual activity of a child who's under 18, I would be pushing back with your own agency. But if that is what you are having to do, then I would be very openly and explicitly explaining that to all youth before you talk with them, because they need to keep themselves safe. And if by disclosing consensual sexual activity to you and seeking reproductive health care from you, they're basically initiating a report. They need to know that ahead of time. So reports must be made in a certain setting, and we're going to go through that. I'm going to talk about the ASVAST tool with you. We recommend screening children for these other situations, not necessarily at every visit, but certainly at their annual well child visit or teenage visit, and then also at any visit where they are seeking care for reproductive health issues. So how to screen? I mean, it's going to be your standard, those of us who talk with teenagers in a medical setting are used to doing that. You're going to have those typical conversations, but you also want to explore if the parent or guardian is aware of what they're disclosing. You want to explain limits of confidentiality and then screen using a tool. This was a beautiful tool that was developed by several people here at Children's, including Dr. Steve Madsen. And I'm sharing this tool with you with his permission. He is now an adolescent medicine specialist at Nationwide Children's, and he has given us permission not only to use the tool, to share the tool, but also we have modified it slightly. And so the tool that you find in your handout is the modified version of the tool that I would encourage you to use. So if you look through this, the very first part of it gives you some situations for patients under 18 years of age. And basically a yes answer to any of these first questions should prompt a report. And those are pretty clear on your handout. So I'm not going to individually walk through those. You can read them. The second part of this ASVAST tool is for patients under 16 years of age. And this is a consideration of reporting. I would say strongly consider reporting if any of the following are yes. And that's in situations where the partner is 5 or more years older than the patient, if the patient is 12 years old or younger, basically that under 13 years guidance that I mentioned before. If the patient is living with their partner independent of either family, or if the patient has ever been physically assaulted by their partner. And then the last section of the ASVAST tool gets at really the ability for the patient to provide or to be in a consensual sexual relationship. And so it gets at mental deficiency or mental illness. It gets at maturity and understanding the consequences of their own behavior, and then explores any situation of exploitation. And then last is, and I don't think this is explicitly covered on the ASVAS tool, but if you have a patient or a client who is explicitly disclosing an assault or sexual abuse, that should be taken very seriously. While false reports do occur, they're relatively uncommon. Local child advocacy centers are really an ideal resource to you after a report is made. If a disclosure is made to you, it should be documented verbatim as much as possible. You need to assess the safety, the imminent safety of the child. In other words, does the parent know about the sexual activity, and is the parent protective? And then a report should be made to both law enforcement and child protective services. And then these kids need medical care. They need assurances. They need mental health referrals. They really need a lot of support in order to stay safe. I'm just looking here to my time. I think we're doing okay, and I'm going to look briefly here to the question. I have a question here. Is Wisconsin state law that a child cannot consent to sexual intercourse until age 18? So people often talk about what is the age of consent, and many states allow 16 years of age was the age of consent, as I recall when I was in Kansas. Wisconsin, the age of consent is 18, but consensual sexual activity without coercion, without some of these other risk situations, between age 16 and 18 is misdemeanor, but it's still against the law. So I would turn to your own agency and to your own legal counsel about reporting consensual sexual activity between 16 and 18, but the age of consent in Wisconsin is 18. I'm going to turn to this case. This was a complicated case, but one that I think is hopefully fairly clear in terms of reporting. It was a 15-year-old girl, and her family took in the 16-year-old boy. I think it was a son of a family friend, and there was some parent-child interaction issues that caused this family to help out their friends and take in their 16-year-old boy for a period of time. And while this 16-year-old boy was living in the home, he and the 15-year-old daughter of the helpful family began a relationship. They began dating. That was her term. And so they had consensual sexual intercourse, at least as far as the 15-year-old's perspective. I don't think that was known to the 15-year-old's parents at that time. But increasingly, the sexual relationship became troubled with some violence between the two of them. And ultimately, it resulted in a violent rape of the 15-year-old and beating of the 15-year-old. So the 15-year-old initially came to medical attention because she was seeking care for some injuries. She also had venereal warts or condyloma. So clearly, I mean, I think all of us would realize this is a mandated reporting situation, but it goes well beyond the situation involving just the 15-year-old and 16-year-old. It also, I think, involves are there supervisory concerns here? I would say absolutely you have at least reasonable suspicion of that. So this would be absolutely a report for sexual assault. It would be a report for physical abuse because this child had been physically hurt, but also for neglect. So it kind of crosses into all of the categories. So I want to touch on a few situations that intersect sexual activity in minors. And my goal here is not to cover these in depth because we don't have time to do that. My goal also is to remind you that at least in regard to commercial sexual exploitation of children or trafficking, that WECAN has given you some webinars before. There are a lot of really good resources, and our state is doing a lot to intervene more effectively and detect these cases more effectively. So my goal here in the last part of the talk is to steer you towards resources but not to cover these in depth. We have about 10 minutes left, and so I'm going to briefly go through these just to remind you that if you want additional resources, Dr. Rabbit, as well as many others in the state of Wisconsin, have developed some excellent collaborative resources, and they can now be found at this medical college, at our website for child advocacy and protection. But these resources have been developed collaboratively between Dr. Rabbit and many others in the state. There is also a training module available at this website. So I would encourage you to go to that website if you're seeking more information. There are also additional places where you can seek additional information, and I wanted to make sure that you were aware of this national website or project, the Polaris Project, which can also be quite helpful. So the second high-risk situation is the risky technology use. And having just come back from the Together for Children conference, I went to a wonderful talk by one of the Milwaukee prosecutors, Matt Torbenson, who talked a little bit about some local initiatives around risky technology use, particularly around sexting. There are many, many resources on this topic, and so I'm really just pulling this up so that you can kind of see what the current recommendations are and where we are in regard to risk. But I think you're going to be seeing a lot more in the near future on this topic. If you are interested in, I don't think WeCan has ever developed a talk about sexting, but we have one of our forensic interviewers, Lynn Cook, and others in the community have really become experts on this topic, and I think in internet crimes and risk. And so if this is something that you would like to see on WeCan, please include that on your evaluation, and we would look to include that in 2019. So just so you know that more than 70% of children under age 12 use a tablet, and almost 40% of toddlers age 2 to 4 often use a mobile device, which is, to me as a pediatrician, kind of scary. The American Academy of Pediatrics recommends no screen time whatsoever under 18 months of age. Between 18 months and 5 years of age, they recommend less than 1 hour per day, and that should be done in while interacting with a caregiver. And I want to steer you to a resource if you want something that parents can find helpful, is this family media plan, which is really quite helpful in managing screen time in a family setting. There are many other resources, and I think just from a time perspective, these are in your handout. I would encourage you to look at them, but I think most of us know that teenagers are using social media sites more and more. Social networking is the norm. If you look at just, this was data that I pulled just April 2018 data, you can look here at the 15 most popular social networking sites of teenagers. And so we know that what the social network of our teenagers looks like is very different than it was 10 years ago or 20 years ago. And we have to adapt our anticipatory guidance and safety messages with this new reality in mind. What teenagers are doing every day, these are high school grads, are doing every day is the new reality. Again, just some resources for you. I have some tips for helping parents that I wanted you aware of, mainly just that you have them, they're in your handout. And then I pulled this actually a couple years ago off of multiple sites, but I put together this slide of what never behaviors should occur, and I think that's probably true for adults, but it's helpful for parents in providing guidelines to children. And So never posting illegal activities, never bullying, never trash talking teachers or others, never posting any objectionable material, or posting confidential information. Checking in with others while you're by yourself because of this geo-mapping that can be occurring, so that you can essentially put yourself at risk if you are checking in live with others while you're by yourself. Never lie, cheat, or plagiarize, never threaten, and never make a post on a social media site when you're feeling emotional or in the basement of your brain, feeling when your amygdala is activated. Other resources that I just recently learned about through the Together for Children conference are here, and I wanted to include these because I've looked at a couple of them and they look like really good resources. And I wanted to mention adolescent physical abuse before we conclude today, because this is, adolescents tend not to report physical abuse. They tend to be reluctant to do so. It's often happening in the context of their own intimate relationships with peers or partners, sexual partners in particular. And it often involves media and technology. And teenagers may be very reluctant to report because they were essentially, it puts themselves at risk. They were doing something they weren't supposed to do. So often they conceal this information. And so when it happens, like this teenager was punched in the face, it may not emerge at all, or it may look a lot like a battering situation instead of your typical physical abuse. So screening teenagers for teen dating violence is really important. This is common. 25 to 60% of teens will experience some type of relationship violence, yet most don't disclose. And we know that teen girls who are experiencing teen dating violence are more likely to engage in other activities or have other mental health issues or substance abuse issues that put them further at risk. So it's important to screen. They don't disclose. How do you screen? Well, we don't have really good protocols to follow, but if you look on the internet, you'll find some. This one, such as Expect Respect, through the AAP's Connected Kids, gives some really good guidelines. A screening question, much like you do an adult, that frames or basically normalizes, makes it okay to tell, is really important, because if you don't set the stage through this framing question, then teenagers will have a great difficulty in disclosing that they've been abused in a relationship. And even if the teenager denies that they've experienced teen dating violence, it's important that you've set the stage that it's okay to talk with you about it and that you can help them, because they are more willing to share this information with their friends and peers and hopefully expose violence if it's happening. So I've put some sample screening questions in your handout, and use those as you're comfortable. And then I've also included some resources. So I'm going to turn, I have some references. I'm going to turn to the question pane with our last minute and see if there's anything else here that I can help with. And it looks like I've addressed the questions at this point. Thank you very much for questions today and for your participation. If you have suggestions for future weekend lectures in the next few months, we will start working on the 2019 lecture series, and in fact, I personally go through all suggestions, and then as a leadership group, we will prioritize those and start pulling together the 2019 lecture series. So thank you, and I'm going to conclude today's presentation.
Thank you, Dr. Sheets.